Welcome to Micro Review. Today our topic of discussion is Clostridium difficile. It causes pseudomembranous colitis. If we talk about the features, as I mentioned earlier that all the Clostridial species are having four things in common. They all are anaerobic, all are spore forming, all are gram-positive rods and all produce toxins. The habitat of Clostridium difficile is colon and its transmission is feco-oral. By feco-oral I mean that Clostridium difficile produces spores. These spores are released in the feces. Spores survive on contaminated surfaces and on hands if they are not properly washed, due to which the spread occurs from hand to mouth. Right? Before going on to the pathogenesis, you should be remembering that this particular bacteria, which is Clostridium difficile, is causing pseudomembranous colitis. And this pseudomembranous colitis is mainly antibiotic associated. So, what are the predisposing factors which lead to Clostridium difficile activity? So, the antibiotic repeated use, the proton pump inhibitors like omeprazole, excessive use, and in healthcare settings. The antibiotics that predispose a person to pseudomembranous colitis are clindamycin, ciprofloxacin, cephalosporin, and carbapenems. All begin from C. Moving on to the pathogenesis, as I mentioned earlier that it is causing a colitis that is mainly associated with antibiotics. So the pathogenesis begins with administration of antibiotics in a repeated manner. Antibiotics alter the normal gut flora, due to which Clostridium difficile gets a favorable environment to grow. Clostridium difficile produces two toxins which inhibit GTPase, which inhibits the signal transduction, which depolymerizes the actin. When actin is depolymerized, the cytoskeleton of the GI cells, which are enterocytes, is destroyed. Once the cytoskeleton is destroyed, the enterocyte death occurs. And this death of enterocytes leads to the development of pseudomembrane, due to which it is known as pseudomembranous colitis. Right? So now if we talk about the details of pathogenesis, that antibiotics like cephalosporin, clindamycin, ciprofloxacin, carbapenems alter the normal gut flora, due to which the normal flora is not able to suppress the growth of Clostridium difficile. When the normal flora is altered, C. diff is growing in an exponential manner, due to which it is producing two toxins. One is the exotoxin A, second is the exotoxin B. Exotoxin A is an enterotoxin which causes watery diarrhea, and exotoxin B is a cytotoxin that causes cell necrosis, fibrin deposition. This is just an important point you should remember. And both exotoxins are glucosyl transferases. This is an MCU point. After the production of toxin, the signal transduction pathway is inhibited, due to which the actin polymerization is not occurring, the cytoskeleton destruction occurs, enterocyte death occurs, and the visual representation of enterocyte death is the development of a pseudomembrane, due to which this is known as pseudomembranous colitis. Colitis means inflammation of colon. Pseudomembrane is not actually a physiologic membrane. It is a pathologic membrane. It is made of necrotic cells, lymphocyte, cell debris, and fibrin, right? So that is why we say that this is a pseudomembrane, and the example is pseudomembranous colitis. When the inflammation of colon has occurred, there would be no absorption in the colon, due to which watery diarrhea occurs, and this is the first clinical finding. Moving on to the clinical findings, the first clinical finding is massive non-bloody watery diarrhea, fever, and abdominal pain also occurs. On endoscopy, which is rarely done, but if it is done, we see pseudomembrane, that is a yellowish whitish membrane which is pathologic in nature, and it is made up of lymphocytes, necrotic cells, and fibrin. And the examples are pseudomembranous colitis or pseudomembranous pharyngitis, which is due to some other bacteria, right? And mucosal ulcerations are also seen on endoscopy. If we have to make a diagnosis that is it really the diarrhea caused due to the Clostridium difficile, because not all diarrhea that is occurring after the administration of antibiotics is due to this particular bacteria. For example, a person is taking an antibiotic and after some time he is suffering from diarrhea. A second person is taking an antibiotic and after some time he is suffering from diarrhea. So would it be good to say that this diarrhea is occurring due to the presence of Clostridium difficile or due to the mechanism of action of Clostridium difficile? Because in some cases the side effect of normal oral antibiotics is diarrhea. So to distinguish the Clostridium difficile colitis, which is pseudomembranous colitis, from the transient diarrhea, which is the side effect of oral antibiotics, we do stool detection test. The detailed diagnosis is written here, that we take a stool sample and we perform 2 tests on it. According to Levinsion, one test is detecting the exotoxin, which is ELISA, and one is detecting the genes that encode the exotoxin, which is via PCR. In some books it is written that stool sample is taken, 2 tests are done, right? One is for the presence of the C. diff, which is the Clostridium difficile antigen, and one is for the AB toxin, exotoxin A, exotoxin B presence. Antigen test, this test tells whether Clostridium difficile is present or not, right? Only it tells about the presence. And this particular test tells that whether Clostridium difficile is producing the toxin or not. So antigen test tells whether Clostridium difficile is present or not, which is the first test. After which we do a test, which is PCR, which tells whether it is producing the toxin or not. So according to Levinson, this is the information, and according to some other books, this is the information. Both are correct. Moving on to the treatment. So the first line of treatment is oral vancomycin or metronidazole. Normally vancomycin is not given orally because it is poorly absorbed. But in this case, we don't want vancomycin to be absorbed, because if there will be absorption, it will leave the colon. And now that is why we are giving oral vancomycin. Due to its poor absorption, it will stay in the colon and it will destroy the Clostridium difficile. The second line of treatment and the treatment to prevent the recurrence of attacks is oral fidaxomicin, right? And the third treatment or the third option is fecal transplant. It is having a very high cure rate, but it is limited due to the patient acceptance. It is very difficult for a patient to accept such treatment, and due to aesthetic considerations, right? In this particular treatment, the feces which are containing the normal flora are introduced via enema, capsules, colonoscopy or nasoduodenal tube, due to which the treatment occurs and it is having a very high cure rate, right? Fourth option is the surgical resection. If we talk about the complications of this disease, this is the toxic megacolon, and if it is excessively complicated, then we have to do surgical resection. If we talk about the prevention, so it can be prevented by doing hand washing, maintaining proper hand hygiene to prevent the fecal-oral transmission. Probiotics like Saccharomyces are given in some cases, and the most important aspect of prevention is that only give antibiotics when required. Never ever give antibiotics immediately, right? So this is how we can prevent this disease. To summarize this particular bacteria, you have to remember that it is causing pseudomembranous colitis. How is pseudomembranous colitis being developed? It is antibiotic associated, and one more point, that cancer chemotherapy also associates or also predisposes to pseudomembranous colitis, right? Once antibiotics have altered the normal gut flora, C. diff grows in a very exponential manner. It produces 2 toxins, toxin A, toxin B, which inhibit the GTPase, and the signal transduction is inhibited, actin depolymerization occurs, cytoskeleton destruction, due to which enterocytes are dead, which is represented visually as pseudomembrane development, which leads to pseudomembranous colitis. When there will be inflammation of colon, there will be no absorption of water, leading to watery diarrhea, which is the main clinical finding. On endoscopy, we see pseudomembranes, or sigmoidoscopy. Mainly on sigmoidoscopy we see pseudomembranes. And what is a pseudomembrane? You should be knowing for viva aspect that pseudomembrane is a pathologic membrane. It is due to any sort of disease, and it is composed of lymphocyte, necrotic tissues, necrotic cells, and it is composed of fibrin, right? And the examples are pseudomembranous colitis and pseudomembranous pharyngitis, which is caused by other bacteria, right? If we talk about the complication of this particular disease, it is toxic megacolon. If this complication occurs, then we have to do the surgical resection. If we talk about the treatment, the first line treatment is oral vancomycin. The reason for giving it orally is that it is not absorbed, it is poorly absorbed, due to which it remains in the colon and destroys the Clostridium difficile. And the second line treatment or the treatment to prevent the recurrence is fidaxomicin. The third option is fecal transplant, though it is having a very high cure rate, but it is very difficult to accept. In this particular mechanism or in this particular treatment, a stool with normal flora is introduced via colonoscopy or nasoduodenal tube, right? And the fourth option is surgical resection. So the diagnosis is based on stool detection of toxin A and toxin B, and also neutrophil level is increased in the stools. If we talk about prevention, proper hand hygiene, only give antibiotics when required, and probiotics in some cases are given. This brings us to the end of Clostridium difficile as well as the Clostridial species. Hope it explains.